known case of diabetes and hypertension, presented with unstable angina. His 2D echo showed normal LV function, LVEF 60%, status post PCI of LAD lesion, mid RCA ISR, followed by a critical de novo stenosis. His syntax score is 12. Our plan is to do PCI to RCA ISR and a de novo lesion under OCT guidance.
Good afternoon. Can we have the stand size? Is there? What was
I
the?
think we are live already.
Yeah. It was put in 2020.
Okay.
Looks like a fairly large artery. As you can see, two lesions. We're going to go cranial and park ourselves in the
Hello,
distal
cranial.
branch. Huh? Oh, Madhunia. Very good. Thanks. Okay.
Looks good.
Okay, both spadiya. I run through any khasiyat. Yeah.
So.
Yeah, we don't have the details of the old stent, what size and all that.
Okay. So what is the plan, sir?
So we're going to first dilate the distal and the proximal lesions.
Okay.
Then we have two choices. We can either OCT everything and then stent, or we can stent the distal first, which looks like a fairly focal, straightforward lesion, although there is no such thing. And then we want to come to the more complex part of the procedure, which is the in-stent restenosis. So what does the panel think?
Imaging followed by the.
Imaging first. Yeah, let me pre-dilate first so we can get good imaging.
Yeah, I think it would be reasonable to dilate and maybe fix that distal lesion
first, right? Yeah.
Because when we fix the distal lesion, we'll be able to do better imaging.
Yes.
That is true. That is true. Yeah. So our original strategy is to fix the distal. So we'll have to pre-dilate, and we'll pre-dilate the mid also.
And we can always go back to that distal and optimize it at the end. Yeah.
Absolutely, absolutely. Let's do a cranial picture. So let's go LAO crane. Yeah, 20L and some crane. Good. A little more cranial. Yeah. Okay, good.
So we are taking 3x15 NC track Neo for pre-dilation.
Let's do a clean shot here. Cine. Cine. Neo. I think I don't notice a big difference, but it's no worse than previous. But then I'm very thick-skinned, so I don't feel many things, Whatever is on the shelf. I really hardly.
We use the NC Emerge as our. I like the NC Emerge. Yeah. Then we have the OPNs for the more difficult cases. So Samir, what do you think about imaging here? You have both options.
I think we'll use OCT because of ISR. We want to get a pretty high definition of what's going on in and outside the stent.
I think that's a
further. Okay, let's go up there.
Yeah, perfect application for OCT. I think is stent failure in general. Yes.
Stent. Right. I think we watermelon seeded back a little bit. So let me advance it a little bit and puff there just a little. Yeah. Just a second. I'll advance it a little more. It's way proximal. Yeah. Now it's flagged a little. So, okay. Let's see. I think it might be in now. Let's puff and see. Yeah.
Yes, we are across the lesion.
Just one second. Let me go a little further. Okay. Now let's puff again. And then. And okay, that's good. Yeah, that's good. And go to 2 and we'll sit there for a second. Can we trap it?
2,
Okay, we got it this time.
4.
Yes. Just one sec. And save that fluoro, please. Okay, we'll
6.
deflate and see.
What size balloon is this?
This is a 3015, right?
Yeah, 3 of
Looks
50.
like a good
350.
size.
Yeah, that's a good size for it. And let me pull back a tad. Ready? Okay,
Yes.
let's do a cine here. Okay.
Yeah, that was perfect.
Tell, what you are going to see in this distal lesion.
The distal
Because there is watermelon seeding and no calcium is seen.
I think it's
it is
fibrotic.
predominantly fibrotic
lesion. Yes,
Yeah.
fibrotic lesion. Now we have treated a 15 millimeter segment, so I'll take a 15 stent, even though I probably could have gotten away with a 12 millimeter stent.
Yeah, that's fine.
But we'll take a 15 stent, right? So we're going to take a 3015 or 27515. Yeah, we'll take middle part also on our way out. Right there. Okay, let's puff.
Yeah,
Okay,
looks
ready?
good.
Yeah,
This must be
Go ahead.
that's a
slippery.
good spot.
Yeah, it's a good spot to start. And
4,
4, 6, 8, 8, 10, 12.
10.
Let's take a
The other
Let's take a
good
cine
thing
here.
about this
14,
balloon now
16,
also
18.
is that
Yeah,
it's
20
a,
is
it's an
20.
unwrapped balloon from the distal lesion,
Okay,
so it doesn't slip as easily.
good.
Deflect.
Okay, down. Okay, so we are a little proximal. We still have a little distal stent there. Let's puff there. Okay, one more inflation distal. Just a second. Okay, go up there.
6.
I think we still need to go distal. It's watermelon seeding up. So let me get the guide in. And we will get our balloon further, a little further. Okay, that is there. And about there. No, that's too far back.
Yeah, that looks
Right
good.
there. That's good. Go up there, yeah.
So once you dilate a lesion, can you image after this?
Yes, we could do that.
Yeah. Before deploying the distal stent?
We could do that, right? It'll be a change from our strategy, but anything for you guys. Okay, so now we are pre-dilated everywhere, so let's take a picture here. Just one second. Ready? Good guy. Okay. And there. Okay. Ready? Let's take a nice picture here. Ready?
Yeah.
Okay.
315, the distal.
Distal, we need a 315. Let me, guys, we'll stick with our strategy. We're going to put a 3015 stent distally, and then we'll do imaging. We can always make optimization, type changes afterwards. So let's take a 3015 stent, and we will deploy distally, and then take a stab at OCT.
Distal synergy, ISR ma chance.
Yeah, you may come back and post dilate this one later.
Yeah, we can post dilate to whatever the OCT says,
exactly.
but
Looks like this artery keeps growing as you dilate.
it does, yeah. The pre-bifurcation area is still 3.0, but it's not more than that, right?
Yeah, I agree.
Yeah, it's okay. Yeah. There's a good.
Samir, there is a large branch coming out of this thing.
Absolutely.
You want to wire it, do a small pre-dilatation over there? It's likely to close.
It probably will, but I don't think we can properly enter it and treat it anyway. It has an awkward angle. It's inside a stent, and probably there is calcium.
And
there.
moreover, it is
That's,
extremely good ischemic preconditioning.
Exactly.
Yeah,
I was
it's
just
a
going to say.
99.9%.
Usually leads to precordial ST elevation if it has sluggish flow like this, and here we don't see it. So it's probably already compensated for.
So, and you also see that there are two other RV branches. So
Right.
typically you want at least to preserve one good size RV branch.
Right.
So I think you have the proximal one and a distal one.
Sure,
I think that will be
thanks.
enough.
Thank you. No, that I agree with that 100%. Well, that's the first little battle one. So let me just bring the guide in. And that looks good there, right? Yeah, good. You want to take
Can
a
we
picture?
take a cine?
Come back Dot probably? Yeah, a
1
little bit
mm
back,
back,
right? Or
yes.
dot back. It's came a little too
forward.
much, yeah. A puff there and right there. Yeah, let's go up here.
6,
Yeah. Jawad.
7, 8,
Saras. Okay, perfect here. That's
9,
good. Ready?
10. Deflate.
Okay. Saras. 10 karyu na? Okay, good.
Cha,
All right. It looks very
compliant
evenly
balloon, so it's
expanded. Very
already
good. Yeah.
3 inner diameter.
Okay, let's bring this back and see how it looks. Okay, go ahead. Puff that, please. Good, good. Okay. Want to take a picture?
Yes.
Okay. It looks beautiful there. Okay, now we'll do an OCT. Yeah.
Samir, I have a suggestion.
Yes.
Here, you take one run of OCT and one run of IVUS and then explain how the stent failure looks with OCT and IVUS. No
Wonderful,
problem
wonderful,
with both.
wonderful. We will do that, and we have,
So, what do you think the OCT findings for this, in-stent restenosis? I think that it is 4 years, 3.5, 4 years old.
I think it's
so. Lot of neoatherosclerosis,
Neoatheroma?
chances of the patient having calcium are less.
Yeah, I agree with you, Chekas. I think the stent silhouette itself looks reasonably sized, and it seems like the lumen loss is more inside the stent, and with the age of the stent, that makes you think it's neoatherosclerosis.
Yep.
Although there is one area in the very distal
पहला OCT करना है
that maybe
क्या बड़ी IVUS करना
Tamara, you want to take the wire in PLV?
है
The wire, you can keep it in PLV.
PRE मुकी दो
OCT તમને push કરવું will be more because you sometimes you need to pass the entire assembly.
That is true. That is true. કે પછી હમણાં રવા દઈએ આમાં છે huh? We had a question. Should we put the wire in the PL so we get the lead time for OCT? I mean the lead length. But I think this will work.
OCT, in fact, you can do IVUS of the distal.
Yeah.
We are interested in the proximal.
OCT. Yeah, for both. Yeah. Long.
Okay.
Yeah. Yeah, it's a pretty long PD. Ready? બહુ સરસ બધું બરાબર છે ભાઈ માશા I got it. There. And yes. We might be able to get both anyway. Yeah.
Yeah, I think that's enough
I think we should
beyond
go.
the edge.
And let me engage it well so we get good dye fill. Ready?
Yeah.
Okay. And Sanjay Veni strict karo
Yes, yes, yes.
Ready to go, guys?
Just
Let
keep
us know
the
when you are
fluoro
enabled
on.
pull.
I'll do it.
You see the lens moving, Aman, and then inject
Yeah.
very fast.
Yep,
Start injecting slowly.
Yeah. Yeah. First fill it up slowly.
Yes.
Yes.
Ready?
Ajad.
Go in
push, push,
now.
push, push, push,
Inject.
push, 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 push,
Super.
push, 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 push. Nice picture.
Perfect.
Nice picture.
Thank you.
That is such a great technique, by the way. Jabardast. All right, let's see. Pressure's good, STs are good, everything is good. He's good. So let's take a look at our images.
The distal stent is fine.
Distal stent looks very good.
one little area of malapposition at the very distal edge.
Okay. 68% is the
It's
MSA.
okay, just
yeah.
ignore it.
Yeah.
Fat and neoatherosclerosis.
So as expected, it is a healed plaque. It is a healed plaque with predominantly what we will see. Yeah, just show, yeah, there is a nodular calcium there in the proximal part. Okay. Now, સ્વામીજી બિલકુલ રિલેક્સ એને જોવાની જરૂર જ નથી. Looks good. Yeah, distal, just show the distal.
Right at the distal edge.
Go to distal, go.
Right there, the three other
Yeah, there's a
Yeah,
little
yeah.
bit of an arc of under apposition, right?
Yeah.
Malapposition.
Yeah.
So what's the size, distal to the distal stent?
Yeah.
And then, how is the distal edge? Edge looks good?
Distal end is 2.6, 2.7, 2.
Okay, that looks like the branch, right?
Yeah.
I think
Now,
it's an artifact due to the bifurcation.
right. Now we come in the distal right. And, okay.
I don't think, come. This
That's
is
the
bifurcation.
distal right. That's distal
This
right.
is distal right. This is, this is actually, less than 3. It is 2.75 or so. 5 is 2.5.
Yeah, right, right there. What's the EEL diameter there? We can measure it, right? Can we just measure
Yeah.
the length? Yeah. Okay. EEL
I tell
right
you
there.
why it looks so, because there is a nodular calcium at 3 o'clock position,
So it says almost
which is
4.
not allowing it to be circular.
Right.
You can, and then go to the proximal edge of the stent and see what the reference diameter there is. Because you can use maybe a 3.5 and see if the
Short
proximal
balloon,
allows
yeah.
you,
Right there.
What's the diameter here?
It's not, again, it is a 2.6,
6.0, so it's 2.6 or something.
2.7.
But how about EEL? If we don't see good EEL,
Yeah,
then
this is, you can see there.
3.5, okay.
Yeah.
I think a 3.25 at high pressure.
Yeah,
3 to
3.25,
5.
but or if it's not available, you can take the
3,
or
I think.
3.5 short.
3.5 short. Right.
Just to
Okay.
close the struts.
Yeah.
Come to the proximal
Okay.
part.
So
and let
that's
us-
the distal. We're going to do 3
let
to
us,
5 balloon. 3 to 5, 12 KOI.
3.25, 12
Yeah.
now, અને ના હોય તો
Yeah, non-compliant.
3.5 નું લાવજો. Non-compliant.
And what's there?
We can do 3 at a high pressure.
This
because
is, I
ત્યાં
tell
we
you,
only
this
went to
is
10
a healed
atmosphere
plaque.
synergy.
You can see
Distal
in the
inflation was
periphery,
only
in
at,
the
10
periphery there is
atmosphere.
lot
3
of
to 5
fat.
કરીશું,
So
બરાબર
it
થઈ
is
ગયું.
a
3
fat
at a high
healed
pressure
plaque.
will work.
It is
22
heterogeneous. It is heterogeneous sort of ISR as per the new classification which was published in 2018 in the by the Japanese group. It falls in the category of type 2. No, yeah, you can see the stand struts. Somewhere you don't see a little stand strut, but it's a very small area. If you can't see stand strut in a majority of area, it becomes type 4. But this
Okay.
you can classify
So,
around type 2.
Yep.
Yeah.
And or type 2B Waxman, right?
Yeah.
It's non-calcific neo-atheroma.
So it's neoatheroma on the inside. The stent looks like it's fully expanded.
So what will be the strategy to
બોલો ને શું?
kill the ISR? We can-
Restent.
I tell you, we will stent it, I think.
Yeah.
See, as per, one Japanese study, and that too, again, Dr. Akasaka's work, they have shown significant restenosis.
Oh, pressure.
We are
Only,
giving adrenaline. Must be
only
vaso.
flow જોઈએ.
benefit
બરાબર છે,
with the
કશો વાંધો
drug-eluting balloon, that too in homogeneous
Pressure came down.
hyperplasia, not with heterogeneous.
Let me remove the thing.
How will you we modify the
puff.
ISR segment? Whether we
So
use
there
the
are two
So it's
stents.
fine.
બરાબર છે. આને પાછું ખેંચો.
Yes, yes.
Yeah, there are two stents. In
Kind
some
of.
part it is seen.
Yes.
વાંધો નહીં.
So that's a problem.
There is overlap, yeah. There is overlap with 2 layers. So there'll be
Yeah.
3 layers there. Wow.
this would be a good case for a
Breaky.
brachy or a drug for
Drug core balloon, yeah.
Oh, that we don't have.
Drug-eluting balloon because already we have 2 stents.
I think if it is not available, I will love to crack it with Wolverine
Just volver it and leave it.
and leave it.
શું કહે છે?
Just the balloon angioplasty.
advantages that at least it's a good size.
Yes.
ઈ વાંધો વેગલ છે. બીજું એક એડ્રી.
Adri, apo. Yeah. We can
Barabar,
get
but
which
everything
size of Wolverine you want.
Distal, yeah, distal to the stent. What is the size? Apdi clean landing zone.
શું થયું? ના કોઈ નથી એવું, હા બધું બરાબર છે. હું ડૉક્ટર તેજસ પટેલ છું ભાઈ. હા, કામ તમારું સરસ થઈ રહ્યું, ચિંતા જ ના કરો.
ફ્લુઇડ એક ચાલુ કરજો.
Fluid out.
તમારે પાણી પીવું
So Tejas sir, just can we brief regarding the further plan of whether we go for the cutting
Cutting balloon,
followed
Wolverine.
by the stent or just plain cutting balloon?
I think plain cutting balloon.
Trio?
We will try to
Which size we will prefer?
Trio,
because-
three. Yeah, trio cutting
three
balloon.
Wolverine.
Three or,
Wolverine, three.
3 or 10 or some, yeah, Wolverine. The blood pressure, I think,
I do.
volume, yeah, we
AP
needed
માં
volume.
pericardial border બતાવી દો.
નથી બધું બરાબર છે. There's no problem. બરાબર છે.
બરાબર.
It's fine, no
Yeah.
problem. This was vasovagal.
True.
હજુ 15 મિનિટ હા. હવે એટલું તો ચલાવવું પડે ભાઈ. આ તો સરસ કામ થઈ રહ્યું છે.
So, distal મારે 3, 2, 5, 12.
3/10 Wolverine, yes.
પછી કે પહેલા લે એનો કર્યો ઓર્ડરનો વાંધો ને યા હા વોલ્વરીન લઈ લો પહેલા પછી ડિસ્ટલ નહીં કરી નાખીશું 3 to 5 and then we'll do another OCT plan, right? Good. So we're going to use the cutting balloon for the in-stent restenosis. Our goal or plan is to not stent, because there is a segment with 2 layers of stent.
થોડું.
The distal lesion looks perfect, absolutely.
Yep. Ready? तैयार? Ciao.
All stented segment we will do the cutting or the mid part only where we feel that is maximum ISR?
We will treat the stented
There
area.
are 2 layers of stents,
Yes,
Anand.
yes.
So
Yes.
we have to do cutting balloon there.
Most of it.
Let's see.
Most of it has
I
a
think
significant
I go a
amount
little
of
further.
lesions.
एक डॉट आगे जवान हाँ बस और एक बार जरा puff कर दे कीजिए yeah one more puff बराबर है this is good I think yeah this is good let's start increasing and that will take a little bit of time 2 and પછી 4 right you guys go one atmosphere every 5 seconds
3 4
Dr. Pancholy, just show us the audience how to deal with the cutting balloon, gradual inflation, deflation, what
Yes.
because yeah,
so
why we are doing such steps, just briefly
Yeah.
describe. Yes, sir.
Yes, so we go up 1 atmosphere every 5 seconds with the Wolverines especially. It's a
6.
the mechanism is the blades actually come out first and then as you increase they dig into the plaque.
And what's the maximum inflation pressure?
I think the rated burst on this is in 14 range.
7
Yeah. Although I have gone to 20 easily on this, but here I think we have very good size. કેટલું થયું?
8
8 થયું ને? Yeah. થોડું let's go up a little bit more. Yeah, like to 11 જતા રહો.
9
10, 11, yeah. And then we'll go to 11 and then come down. The
10.
distal edge of this balloon has still got a little bit of a waste on it, but it'll probably,
11.
it's still smoothed out quite a bit. Okay, 11 and then we'll come down. One of the built-in benefit of the cutting balloon, I believe, is the amount of time it stays up. And I think balloon inflation time is undervalued. We go up and down very quickly. Let's go up there. Yeah. And with a cutting balloon, you don't have a choice. You are forced to stay up for longer.
And deflation also should be gradual or the
No, deflation, from what I understand, can be rapid.
okay.
2
So we're going up 1 atmosphere every 5 seconds, roughly.
3
The 3 blade situated one the 90 degrees. So we have to reposition for the orientation of cutting again reintroduce because
I don't know how much of that fine tuning is actually possible or happening, even if you try it. You know, it may not be feasible. I mean, we think we are doing it, but it doesn't happen.
no, practically not possible.
Yeah. Once we reach 6 atmospheres, the blades are fully expanded. Then you can go up faster.
6
So 6 pachi you can dial up nicely, quickly anyway. Yeah.
8
8, 10, 11 karo. Pachi then let's take a cine and see how it looks.
11
Yeah, looks better. Yeah, looks better. Okay, we
Go
can come down, right? Yeah, and then we'll do one more proximal, right? I think there is still an area above that which is a problem. Let's take a puff here and see. Ready? Go ahead. I think that's good there, right? Tejas, what do you think? That spot is good? Okay, so we'll go up there. And again, the first 6 atmospheres are painful because we have to go up one every 5 seconds. And I normally look at the heart rate, and if it is luckily 60, then I count 5 beats. Because
Oh, that's a nice idea.
it's a royal pain. But it is a very good device. I have to say, Wolverine, I think, is different from other scoring balloons. Definitely different. Even though it's classified with other balloons, which are similar scoring.
Samir sir, this is Dr. Jay from Ahmedabad.
Yes, sir.
Sir, in such type of scenario where the
Fluid up, eh?
segment is straight,
Yeah.
but if at
Go
all
on.
you want a differential cutting,
10.
then in that case, would you like to go ahead with the scoring balloon, or
Yeah.
Wolverine will take care of those things? And second question is that
પાછું
such
વાદો વેગા
થોડું
તારી
વચ્ચે
battery આપી દો.
expanded, yeah.
there are 2 layers of stand. So in that case, would
So
you
picture
go
maybe.
ahead with the another stand, or would you like to go ahead with DCB, drug-eluting balloon?
Sorry, ready? Yeah, so I think, anywhere that scoring balloon works, this will work. Yeah, expansion, I mean, lumen-wise, it looks good. Right at the distal end, there is some haziness there. So,
I think this is the part that may need a slightly larger balloon because the size of the artery is you use the 3O, so the size of the artery is bigger down there.
or should we take this balloon and go to higher pressure there?
Try to go to higher pressure down there.
Yes, we can park it there and go to higher pressure.
See, both these branches are still preserved very well. Scout, चिंता ना करो.
બધું બરાબર છે. હા, ચલો, let's see. And let me go forward. ધીમા શ્વાસ લેજો સાહેબ. એક મિનિટ. બધું બરાબર. પફ કરજો. પફ થાય. અચ્છા, સરસ.
કોઓપરેટ નહીં કરો તો આવું આમ મગજ से થોડું ચલાવી લો.
Puff કરજો. I think that's good, right? Okay, let's go up there. Let's go up there.
Adrenaline is working, okay.
Yeah, now, yeah, let's, અહીંયા કરી દઈએ. Yeah, let's go up there.
Fluid થોડું fast કરો.
Yeah. Up to 2, right?
1.
1. Okay. I think that's the right spot. Yeah. Maybe a little bit above where we need it to be, but we'll see. Although we got it, I think, yeah. I think we got it. We can go up to, once you cross 6, we go up faster, yeah. The patient is a little anxious, so we are in a little bit of a rush there, but
Yes.
let's go up a little bit higher. Go to 14 or something. Okay, we are up to yeah. Good, okay. I think that's more than enough, yeah, more than enough, yeah. Expansion wise, best looks better. Okay, let's puff there and see. Puff, okay, good. Let's take a picture here. I think it looks much better. All right, let's take that 325 balloon. We'll do the distal 325 12. Ready? 35. We can take a 30 and go higher. Give me a 30 12 and we'll go to 20 24 atmospheres. Looks much better than it did, yeah. And the side branch is preserved, guys, by the way. Somebody in the panel had a concern about side branch.
You know why it is preserved? You can see it looks sometimes to me like it's not 99.
It probably is occluded and there's collateral, yeah. It looks beautiful. બહુ સરસ. ચલો આ લઈ કાઢ લઈએ. Beautiful. So the Wolverine did a better job than I expected. We'll take a trio, yeah. Yeah. We'll take a short a trio and high pressure dilate the distal stent and then OCT. Very nice.
Okay.
Are you all right?
Yeah.
Okay, good.
So we were talking earlier today about the future
Okay.
of these types of cases when drug-coated balloons are going to be more available. This would be a
Thank
good
you.
application for that when you want to avoid stenting.
Okay. Are we in stent? 15 check a 12. This looks a
15 check
12 channel. Acha 12. Acha, let me go a little further and stay inside stent on both sides. Let me just cine. I think we are inside stent. This is good. Yeah, let's go up here. Yeah, this is 3-0, so we have plenty of size comfort. So that's what, 14, 10, 11. Let's go to 14 and 16, 17. Then we'll sit there and let's give it a good 10 seconds of expansion and it'll probably get better.
The distal edge, I think we missed.
Yeah, but that's where the under apposition was, right?
Yes,
so we'll
yes.
probably engage that. Yeah.
This
Is
side?
that decay? Decay is on thoda. Acha. Okay, down we will come a little further. Okay. I think it might dissect there, yeah.
Now can you hear me?
Yes, yes.
Samir, I am afraid that that at that place there is a nodular calcium.
It might tear there, huh?
Yeah, so you can go at around 15.
Right. Let's go up there for a
You
little.
can be conservative here because
Yeah.
the problem was more the distal edge.
Yeah.
Which you took care of already.
Okay.
Yes.
Yeah. Go up there for one more
Senior?
time. Yeah. Yeah, let's go up there and we'll see how it looks. एक बार लगाई दिए थे हमने बस पति कितना सुधी 11 12
10, 12.
अच्छा where is it?
Senior.
No, just put up.
There we go. Okay, down.
Okay, looks good.
Okay, down. Very nice. Okay, now we'll take everything out and we'll do an OCT run. Wire. Okay, good. Okay, good.
Dr. Saito is ready inside.
Okay, अब आवाज करो जो OCT करो करवा दिए ना right. Okay, good. So we'll do OCT this time again. Ready? Okay. Slack up, Okay, I got both. About a cranial, so I can.
Yeah,
I can.
you've almost crossed.
Yeah, let's go cranial, so I can
Eleocranial.
park the wire all the way, and then take the OCT catheter. Alright, just a sec. Okay, now we will get everything, right?
Yes.
Yes.
I think
okay.
yes, everything is
Yeah,
covered.
wire is a little crinkled up. Okay, ready?
Yeah.
Yeah.
Okay, ready to get OCT, guys?
Fluoro.
Live view. Pressure barabar hai? Saras.
Yeah, fine.
Ready? Ready? Go. Okay, now, okay. Now inject. Oh no, I think we'll have to do it again.
It's stuck
Yeah.
there, I think,
It's
in the small branch.
Getting stuck.
It's not moving.
So here I tell you.
No, it did move, but it moved afterwards.
So here
We had to give more delayed injection.
Slow and extremely delayed injection.
Yeah,
Yes.
right. Okay. Why distal wire?
No, no.
Yeah. Distal.
No, OCT.
Yes. Oh dear. No, we got a little mangle there.
What I feel is
Why get entangled?
Yeah, wires tangled. So
Yeah.
Everything back.
everything. Remove everything. Yeah. And I can rewire it probably. Yeah. There we go.
Okay.
Yeah, that's
Okay.
That's
better.
PLV is the
It's a
better
better
branch.
branch.
Yes, for OCT.
Okay. Good.
Careful.
Okay. Yeah. My guide's a little back, so let's take it. All right. We have it.
You're off the wire, I think.
Sam, the OCT
Oh
is
yeah.
off the wire.
We are off the wire. Yeah. We'll have to come out. Yes.
you have to rewire.
We have to rewire the OCT. So, good. Thank you for that reminder. Should have known, but we got too happy about the wire.
While you're doing that, Dr. Patel, can I ask in terms of sizing strategy for cutting balloon, in this vessel, the stent appeared to be 3.5 on the OCT from what I could make out here. So if it was a native unstented segment, what would you size?
3.5.
And because it's a stented segment, how can
And
you
yeah, we don't know what happens in the stented segment with 2 layers of stent.
Okay.
So you have to be little conservative on it.
Okay, a little more.
Okay.
More. Hey, beta. Angela, baju le li. Wire. Need more slack अजित थोड़ा हाँ अब जाओ देश वायर नहीं चल थोड़ा ये हम ले लो बस okay now it'll go little more slack little more slack okay good
Yeah.
that should work okay ready ready yes
Ready?
Go. Yeah, go. Beautiful. All right, this will be good.
Yeah.
Very
This
good.
will be good. This will be good.
Yeah, very good.
બધું જાયગું.
Huh?
We
Well,
covered
yeah, we
everything.
got both stands.
76 millimeters, 74
Stand looks better.
Yeah.
Perfect, Pati.
Yeah, perfect. Yeah. Distal edge is okay and proximal edge is okay. Position is okay, right?
Yep.
Everything okay, right?
Yep. MSA is 89%.
Yeah, 89%. Yes.
That's very good. Yeah.
Yeah.
And
This
now
is
comes the in-stent restenosis.
so yeah, we can
Looks
like-
very good actually.
Yeah. Yeah.
Looks very nice. That's the dye, and lumen looks
wording.
beautiful.
Yes. Right.
I think we're done.
Distal
we can leave it.
edge, no dissection, position is okay, right? No tissue protrusion.
Yeah.
A small amount of tissue protrusion, it's okay. Yeah.
Yeah.
Dr. Akasaka, what is there at the level of 40?
Level of
40. 40.
40, okay. Around here?
Yeah, just come, proximal.
Yes.
What is that?
Is it branch?
This is branch.
Yeah. Ostium of the
And
branch.
some fibrolipidic with macrophage accumulation here, right?
This is
Okay.
a cholesterol crystal.
Yeah, yes, cholesterol crystal here, right?
Yep.
And here is the stent, right?
That's the old stent, right?
Yeah, all the stent. Yes.
Good lumen, beautiful round
Yeah,
lumen.
yeah. And also,
And yeah, 4 millimeter area. The smallest area is 4.1.
right.
No, 3.2. Okay.
Here is a calcium within a stent, right?
Yeah.
So it might be very
Now
difficult.
the
to
question
diagnose.
is, is that worthy of putting another stent or just leave it be?
I think
Let
here
it
is
heal.
the calcium, so if you put a stent, it might be difficult to
Expand it.
dilate.
This is good.
So
Leave it be, right? Yeah.
if you want, try to use an IVL, right? It's one of the treating possibility.
Wow.
Right. But I think
I think let it heal. Let it heal.
yeah. And
Let it
some-
heal.
Yeah.
Okay.
Is an OPN an option?
No, I don't think so.
Should we remove the
A larger size cutting balloon 3.5.
OCT cardinal?
OCT cardinal?
Yeah, larger size cutting balloon should be okay, but this calcium site is difficult to
Yeah, I
dilate
think-
more, right?
I don't think anything is going to expand that because
Yeah.
there's a stent on the outside and
Right.
the calcium is trapped inside the stent.
Yes, calcium, and also the outside
Yeah.
stent, we can
Yeah.
identify the calcium.
We are not going to break
Yeah.
the calcium small enough to come out of the stent.
Right.
What do you think, Khalid?
I think you can do a number of things, but none of them are going to be guaranteed to work. I don't think it's a bad idea to let it heal, and if it needs something else done at a later time, it's fine. But it may heal okay, and I don't know if sometimes you know exactly what's going to work. I don't think here anything is going to be guaranteed to work.
Right.
Yeah.
And it's not a good idea to subject him for bypass surgery for
one vessel,
one
yeah.
vessel, that to the right artery.
Nah. Yeah.
Yeah. So
We pull wire and
this is,
see.
yeah.
Yes. Yeah.
Just
We'll-
a couple of pictures.
Let's take a puff one, just make sure nothing mechanically bad
We
is
just
going on.
see the distal areas, Samir, for perforation
Yeah,
or something.
exactly. Yeah. Let's puff there. Yeah. Looks good, right?
Yeah. Remove it.
Yeah.
No problem.
That branch is having a little delayed flow. Okay, let's take a picture, Sine. And ready?
Yeah.
Yeah, it looks good.
I think it looks as good as
Yeah,
we
it
can
looks
make
good.
this look.
Both the RV branches are pretty
Yeah,
well
let's
preserved.
do an RAO also. Let's see.
RAO plane.
Yeah. So mid will be seen in two views. Away from us. Ready?
Yeah.
I think it looks reasonable
Yeah.
to leave
Yeah.
be and,
Yeah.
and let it heal, right? Even that spot which we were worried about
Yeah.
is not. Yeah, it's not obstructive looking anyway. So
Yes.
excellent.
So, excellent.
It's
Samir,
good.
I
Thank you.
think we conclude. Thank you very
Thank
much,
you very
Samir,
much.
for
Thanks.
very good discussion and nice demonstration.
Thank
now
you.
we
Thank
will
you.
be switching over to the South Lab with Dr. Shigeru Saito along
Khaled,
with our team. Yeah, please. Side also.